Good morning, everyone. Um, Thank you to all who joined us for our early morning third learning collaborative. My name is Clement, and I'm the pharmacist with the Northern New Jersey Center of Excellence. As part of our goal to provide education and support for providers who treat opioid use disorders, we're running these bi-monthly learning collaboratives to help facilitate and support you in your practices. In an upcoming listserv email, you'll be receiving full learning collaborative dates through March 2020, and we'll be provide the links to register. Today's topic will be on the opioid use disorder in pregnant patients, which I know is a very complex topic, which many of us will encounter in our practices. So first off, I wanted to mention some housekeeping rules. Please ensure that you're muted during the presentation and at all times when not speaking. If you're on your computer, press the microphone button on the bottom of the page to mute and unmute yourself. You will automatically be muted upon entry to this presentation. Please hold all questions until the end of the presentation, and you may use the chat function to ask your question or mute yourself, but just please remember to remute. If you have any troubleshooting issues, please send a private chat using the chat function on the right of the WebEx screen. And I just want to make sure, is everyone able to hear me? I think everyone should be. I see two people join via the phone. So today we will have Dr. Damali Campbell present on this very important topic. Dr. Campbell is a board-certified OB/GYN and addiction medicine physician, as well as an assistant professor at the Rutgers, New Jersey Medical School. She completed her OB/GYN residency at Mount Sinai School of Medicine at the Jersey City Medical Center. Her practice is primarily in OB/GYN, in addition to other interests and initiatives that include decreasing preterm labor rates through implementing group-based practice, prenatal care, improve breastfeeding rates, improve gynecologic care of HIV-infected women, and improve general care for women with tobacco and substance use disorders. So without further ado, here's Dr. Campbell.
Thank you. Thank you. Welcome. Happy New Year and happy early morning to everybody. Thank you for joining us. So we're going to go ahead and jump into this topic, and I'm hoping that there will be time for lots of questions at the end. So I have no disclosures, but I did want to mention that I am a member of the New Jersey Maternal Mortality Case Review Team, and we review the death of all women in New Jersey, women that die within 1 year of a pregnancy, regardless of how and when that pregnancy ended. Today, we're going to try to cover a couple of objectives, reviewing the unique factors to consider in dealing with substance use disorder in pregnancy, review the recommended treatments for opioid use disorder in pregnancy, and recognize the postpartum vulnerabilities for women with opioid use disorder. So growing numbers of women for several decades have been using nicotine, alcohol, as well as illicit substances. And in the 1990s, we also noticed that there is a rising use of prescription opioids for non-medical purposes. In almost a decade-old national study on drug use, approximately 55% of women of childbearing age drink alcohol, 23% of women in childbearing age smoke cigarettes, and 10% use illicit substances or prescription drugs without a prescription. And these are all numbers, like I said, about a decade old. We're hoping for some new data, but these are all women of childbearing age. So it may be interesting to note that in 2020, 2019, 2020, still 45% of pregnancies are unplanned. And actually, this number is increased in women with substance use disorder. So almost 85% of women with substance use disorder, their pregnancies are unplanned. And so I believe asking the question, all of us providers, asking a woman, do you want to be pregnant in the next 1 year, would open up an opportunity for providing contraception, particularly for women who are in recovery, because if we don't ask the question, we don't know what their intention is. And if we do know that they have an intention of becoming pregnant, then we can kind of discuss some of the issues before they get pregnant. It's also confounded by the fact that many women who are opioid dependent may have irregularity in menses, so I think it's not unreasonable that facilities would consider periodic pregnancy testing for women who don't have reliable contraceptive methods that they're using. So most of the major professional organizations recommend universal screening for patients, of all pregnant patients with substance use disorder. And the organization ACOG, the American College of Obstetrics and Gynecology, actually additionally recommends screening for the annual Well Women visit. If we only screen on risk factors, we're going to miss an opportunity to diagnose and to treat some patients. And unfortunately, we are typically under screening Caucasian, affluent, and certain immigrant populations. I think, the best way to ask this question is to do it in a non-judgmental manner and to try to make it part of your habit and routine. And so I have started to incorporate these type of questions into my practice. As an example, how many cigarettes do you smoke per year? In the past year, how often have you taken the pain medicine, Tylenol, codeine, Percocet, for pain? If you have, was this prescribed by whom and when? And I think asking the question in a non-judgmental manner will help us to increase our detection rates. So about 5% of women in pregnancy use illicit substances. And I think, trying to nail down this percentage is interesting because currently in 11 states and the District of Columbia, marijuana is legalized, so it's no longer considered illicit. But we also know that a lot of the times the screenings that we're doing don't pick up everybody who is using substance. So there's also a misuse of prescription, Percocet, oxycodone, and Vicodin. And so that 5% number may be somewhat of an underestimate, but it's the best information that we have at this time. It's my belief that, data shows that the majority of women who intermittently use illicit substance will be able to discontinue on their own. But these women still warrant counseling because even though they may quit, they can have relapse during times of stress. And this is an opportunity for us to suggest positive ways of dealing with stress, such as exercise, meditation, journaling. If we don't address the stress in women's lives, when they do encounter it, they may relapse into using substance again. And so it's an opportunity for us to change some habits. So for most obstetrical practices, we try to screen at the first prenatal visit, and the most commonly used screening tool is called the 4P screening tool, and it comprises 4 questions of whether the patient's parents, partner, have had problems with drug or alcohol use, if the patient themselves in the past have had difficulties in their lives because of alcohol and other drug use, and in the past month, has the patient had any alcohol or drug use. And so this is pretty common amongst many obstetrical practices and probably the most common screening tool. But there are other screening tools that can be used in pregnancy. There's the NIDA Quick Screen. And I also just wanted to bring your attention to the CRAFT, which is validated for women 26 years and younger. And it really brings up some other issues. Have you ever ridden in a car driven by someone who was intoxicated or using alcohol or drugs? Do you ever use alcohol and drugs to relax? Do you ever use alcohol and drugs when you're alone? So these are some other interesting lifestyle behaviors that we may need to question to see if there's an increased risk of substance use. There are some practices that use routine drug testing or drug screening as a method of screening, but this is considered controversial, and you need to be aware of what the reporting mechanisms for the area that you're in. In New Jersey, there is not a mandatory reporting mechanism for providers, but there is a mandatory reporting mechanism for hospitals. So the other thing is that if you are using routine drug testing, patients should know and they should consent to that because the patient-provider relationship, the trust can be broken if we're testing patients without their knowledge. Some of the other concerns with doing routine drug testing is that all of our routine tests don't pick up all of the substances. Some of the designer drugs, fentanyl, synthetic opioids may not be picked up by routine drug testing. Of course, routine drug testing doesn't pick up alcohol, and urine drug testing does not rule out sporadic use. So if we're just using those tests without really talking to the patient, again, we may miss an opportunity for treatment and counseling. So, the definition of opioid use disorder, I'm sure many are already aware, is characterized by tolerance, by craving, by inability to control use, and continued use despite adverse consequences. These recurring symptoms in a 12-month period, and we generally grade the severity of opioid use disorder mild, moderate, and severe based on the number of these symptoms, 2 to 3 for mild and 4 to 5 for moderate, and 6 or more would be considered severe. So what's unique about pregnancy?
This is strange.
So pregnancy, helping a pregnant woman recover from opioid use disorder can be very challenging, but can be equally rewarding. Patients typically have extra motivation to achieve and maintain sobriety for their unborn child. But there are physiologic changes in pregnancy that can present challenges for the patient and also treatment challenges for us as providers. Many pregnant women who have substance use disorder feel guilty. They're very fearful about whether the substances they're using are going to affect their child, and if their child is going to be drug dependent. Some of these feelings come from misconceptions that are perpetuated by society, perpetuated by medical providers that are unfamiliar with substance use disorder and treatment, and as well as the patient's own family and friends. So it's important that when patients get into care, that we can correct some of these misconceptions. And so there are a lot of pharmacokinetics that are unique to pregnancy that, as I said before, present challenges for the patient and treatment challenges for providers. So in pregnancy, we know that there is an increase in the glomerular filtration rate. There's an increase in the metabolism of drugs that generally can occur starting in the second trimester and through the third trimester. And there's an expanded blood volume in pregnancy, and that occurs to help bring adequate uterine blood flow to the fetus. Sorry, we're having a little challenge with advancing the slides. So how do we assess the pregnant patient with substance use disorder? It's an extensive assessment. We want to find out about any prior pregnancy history and whether the patient was opioid dependent at that time, the status of that child, and the custody of that child. We want to find out about prior treatments that the patient has received for substance use disorder and whether those treatments were experienced as positive and negative, because it really does influence what the patient may be willing to accept for this index pregnancy. We want to get a true picture of all of the substance use, alcohol use, whether marijuana use is involved, nicotine, as well as prescription and over-the-counter medications. Of course, we want to have a complete medical history, including but not limited to seizure disorder, hypertension, HIV, and mental health treatment. It's a good, we want to find out about the patient's feelings about the current pregnancy and their decision on how they're going to proceed with the pregnancy, if they plan to terminate the pregnancy or they plan to continue the pregnancy. And if they plan to continue the pregnancy, if they've made a decision about whether they will parent the child or not. And of course, with all these questions, we need to have the appropriate resources and referrals. In addition, we want to find out about the involvement of the father of the baby, as well as the family support that the patient has. And in addition to our routine prenatal testing, we also want to get metabolic panel. We want to screen for hepatitis B and C, syphilis, and as well as test for tuberculosis. So this is really a very extensive medical and surgical and laboratory evaluation. So when we do diagnose a pregnant patient with the opioid use disorder, the treatment and the standard of care is as that of any other patient. It is comprehensive. It includes not only medication, but counseling and oftentimes family therapy. And I can't tell you how many times I've had families in my office because explaining to the patient is one thing, but if I don't explain to their family, then again, we're not having a complete understanding of the picture. Nutritional education, and as well as other medical and psychosocial services. Sometimes these patients need help with legal advice, with housing, and with food. So there really is a comprehensive treatment plan that we want to put in place for patients. And so the medication treatment options for patients with opioid use disorder include primarily methadone and buprenorphine. There are some patients who don't want to take any medicine. They want to abstain from using any medical treatment, but that's really not recommended for pregnant patients. And of course, there is naltrexone. Again, the evidence is limited, and we'll talk about it a little bit more. So the two treatments that we really are left with are methadone and buprenorphine. Again, so I wanted to present a case of a patient that I've seen, and just to give you a flavor, make it a little interesting. So a few months ago, we had a 25-year-old patient, her first pregnancy. She presented for prenatal care at 25 weeks of pregnancy. She had a history of IV heroin use. She and her partner, she had a partner who was sober. Both she and her partner were working, and she had been stable in recovery for about 3 years on 70 milligrams of methadone. They were referred for prenatal care, and amongst their concerns was that over the past month, the patient had increased cravings and had began to use illicit drugs in the evening to combat those cravings and prevent withdrawal symptoms. So, what's going on here? Here's a patient who's been pretty stable in recovery for 3 years, and now all of a sudden she appears to be relapsing. And so, again, it's a situation where we're looking at how is the pregnancy affecting her substance use disorder. She was, afraid of disclosing. She did disclose her increased cravings to her program, and they were planning to schedule her to see the physician, but she was fearful that they might discharge her from the program because of her relapse of illicit substance while she was on methadone. So, of course, we are aware that methadone is a full opiate agonist, and typically the half-life for methadone is 24 hours. And so for most patients, methadone is dispensed on a daily basis from a registered opiate treatment program. For patients who are pregnant, they still must go through the registered opioid treatment program, and their dosages are usually managed by addiction treatment specialists. And as with any patient, their doses are generally titrated based on their symptoms to avoid withdrawal. If we encounter a patient who is medication naive, methadone can be initiated in the hospital for pregnant women who are in opioid withdrawal, and the physician does not need to be an addiction specialist or ex-waivered, but the maximum dose allowed per day is 30 milligrams, and then we have to be very vigilant about arranging follow-up so that there's no missed doses. But I want to go back to our case and what was going on with our patient who had been stable in recovery for 3 years and suddenly started to have increased cravings in the evening. So again, in pregnancy, methadone doses, it's not uncommon that methadone doses may need to be adjusted, and that can be adjusted in 2 ways. Sometimes the methadone dose can be increased, but there's more increasing evidence that split dosage to twice a day may be more effective in pregnant patients. And that's because there's a rapid metabolism of methadone that can develop in certain patients in pregnancy, particularly in the late second trimester and third trimester. And so again, with the rapid metabolism, with the increasing maternal blood volume, we see that some patients, not all patients, but some patients will experience an increase in cravings in the evening. And so that was what was happening to our patient. Again, not all women will require dosage alterations. So adjustments shouldn't just be made automatically. They should be made on a clinical basis. And a lot of providers and even patients and even families are concerned that the baby will be opioid dependent if the maternal dosage of methadone is higher. Okay, we have lots of evidence to show that that is not the case. So there is no need to minimize the methadone dose to try to minimize neonatal abstinence syndrome. The treatment goal is really to minimize the patient's symptoms and to prevent relapse. If we don't adequately dose pregnant women, we're going to lead them to be in withdrawal, fetal stress, and have cravings and relapse. So again, part of the pharmacokinetics is that the cytochrome P450 enzyme system is revved up by the hormones of pregnancy. And both methadone and buprenorphine are both substrates to the CYP450. But the difference is that when methadone is broken down, its metabolites are inactive, versus when buprenorphine is broken down, it's broken down into 3 active metabolites. And so what we find is that even though Both drugs have increased metabolism by cytochrome P450. Because of those active metabolites in buprenorphine, most patients don't end up needing to have an adjustment of their buprenorphine dose if they've been stable on a certain dose in pregnancy. Again, the end goal of therapy has to be individualized for each patient, and the end goal of therapy is to prevent withdrawal.
So when we look at methadone versus buprenorphine, we can compare and contrast. The physician's goal is to stabilize the pregnant woman on a therapeutic dose of medication as quickly and as safely as possible. Some patients will have a preference for one treatment over the other, which should be considered after counseling. If the patient is treatment naive, we can start with buprenorphine and transition to methadone if the patient reaches the therapeutic ceiling. Transition from methadone to buprenorphine during pregnancy is not recommended because of the length of action of methadone, and giving buprenorphine can actually precipitate withdrawal. Transitioning from buprenorphine to methadone is a little less complicated. But we can see that in terms of looking at buprenorphine, we have decades of research that supports a high rate of maternal recovery. There is safety with induction on buprenorphine with no risk of precipitating withdrawal. Some may consider some of the limitations of access through only licensed federal programs, and there are many drug interactions with methadone, versus buprenorphine, which is more widely available if the physician has an X waiver, making it easier and more accessible. There is a risk of precipitating withdrawal if the patient is not in withdrawal, but it does seem that you can reach a more rapid stabilization on a therapeutic dose. And there are less drug interactions with buprenorphine, and there's no adjustment that is typically required during pregnancy as there is with methadone. So one of the studies that we should all be aware of is the maternal opioid treatment human experimental research, the MOTHERS trial. This was a comprehensive research effort on the use of methadone versus buprenorphine for the treatment of opioid use disorder in pregnancy. This study is well known and widely quoted. And while there continues to be analysis, there are many lessons learned from this study, and amongst those are that buprenorphine is safe and effective as a treatment and an alternative to methadone for treating opioid use disorder during pregnancy. But the dropout rate due to medication dissatisfaction was significantly greater for buprenorphine than methadone. Buprenorphine, as you probably already know, is a partial agonist and partial antagonist. It acts at the same mu receptor as heroin and methadone, and its function as a partial agonist makes overdose less likely than with methadone. It needs to be initiated when the patient is in mild to moderate withdrawal to prevent precipitated withdrawal. Buprenorphine is available as a mono product and as a combined product with naloxone. There are fewer drug interactions, as mentioned before, and it is the only opioid agonist approved for the treatment of opioid use disorder in an outpatient setting, which eliminates the need for daily dispensing. Infants exposed in utero seem to have a milder NAS. Those infants exposed to buprenorphine in utero seem to have a milder NAS as opposed to methadone. Although we should be aware that the mono product, buprenorphine without naloxone, does seem to have a higher potential for misuse. Some of the disadvantages of buprenorphine include that you do have to start the induction when the patient's in mild to moderate withdrawal, and if you don't do that, or the patient's not able to do that, then you can precipitate withdrawal. You can have a rare hepatic dysfunction, and there is an abuse or diversion potential. There is a limited knowledge on the long-term effects in exposed infants and children, and we're still getting more information about that. We continue to study these infants, and it's inappropriate probably for patients that require intense supervision and more structure. So we have a case of a 27-year-old opioid-dependent patient who attributes her opioid dependence to pain pills that was prescribed after a motor vehicle accident. The patient, for the last 6 months, has been trying to wean off buprenorphine 8 milligrams, but since finding out about her pregnancy, she's been dividing the film into pieces to last for 2 to 3 days. The patient is referred for continued treatment, and we checked the PMP, but found there were no buprenorphine prescriptions on file. So what was going on here, and how do we proceed? So again, this case just points out the fact that this patient was taking buprenorphine, but because there were no prescriptions noted in the PMP, we identified that this patient was getting her buprenorphine off the street. So we had to have a discussion about the fact that that's inappropriate. And while it's good that she was trying to wean herself off of pain pills, we want her to be in a program, get her prescriptions legitimately, and to really be in recovery, especially since she's motivated to do that for her pregnancy and for the safety of her child. And we had to explain that when she's dividing the film into pieces, she may not be necessarily getting a stable dose. So what about medically supervised withdrawal? There are patients who are not going to accept opioid agonist therapy, or treatment is unavailable. And so medically supervised withdrawal can be considered under the care of a physician with experience. It's not generally recommended for pregnant women. It's associated with much higher rates of relapse and poorer pregnancy outcomes. More recent studies, though, show that there's no clear association with medically supervised withdrawal and fetal death and preterm labor. And as you can imagine, there are lots of confounding factors. Patients have multiple risk factors for fetal death and for preterm labor who may also happen to have opioid use disorder. But if one was to undertake medically supervised withdrawal, it should be done under the care of a physician with experience in perinatal addiction, with informed consent of the patient, and in an intensive outpatient, with intensive outpatient behavioral follow-up. And we usually treat the patient's symptoms using IV fluids, clonidine, Benadryl, Vistaril, and sometimes morphine. Naltrexone is a non-selective opioid receptor antagonist, and it blocks the euphoric effect of opioids. It's administered orally or by injection. The injection appears to be more effective than placebo. There's limited information regarding its use in pregnancy, and there seems to be some studies. There are studies that show animal effects, but no human studies, and so we can really just say unknown fetal effects. There are a number of people who continued use during pregnancy, and that requires ongoing and in-depth counseling because there's really limited safety data. And what you're weighing is the limited safety data that we have versus the risk of relapse if treatment is discontinued. So thus far, we've talked about the care of the pregnant women with opioid use disorder, and we can divide their care into their pregnancy care or prenatal care, their intrapartum care, their care during labor and delivery, and then their postpartum care. And all of those individual parts have specific things that we want to pay attention to. So for instance, in prenatal care, we want to take particular attention in testing for sexually transmitted infections, screening for depression, consulting before labor with anesthesia, and having a very extensive discussion and repetitive discussion about breastfeeding and encouraging breastfeeding for the woman who's stable on medication-assisted therapy, screening for tobacco use, and postpartum, we really want to pay particular attention to, again, if mom is stable on MAT, the benefits of breastfeeding and how that can decrease the severity of neonatal abstinence syndrome, the importance of continuing MAT, because this postpartum period is a period of high vulnerability. There are many triggers for relapse. And then we want to talk about the contraceptive options, because for women, we don't want them getting pregnant back-to-back, but in particular for women who are in recovery, we want to have good spacing of the pregnancies so that they will have time to continue with their recovery and have adequate time to bond with their infant. Besides the usual prenatal care, again, when we have the patients in early, it allows for additional consultations with anesthesia regarding pain management, particularly when we're thinking about intrapartum care. And I think it's really important to be able to have a discussion with patients about what's going to happen in the hospital referral to Child Protective Services because of the patient's history of opioid use, and even though she's in recovery, and explaining to the patients that Child Protective Services sees them when they're in recovery as a positive thing, and that they're really just trying to make sure there's a safe plan of care for the infant. So it shouldn't be seen as a punitive measure. Medication amount does not dictate the severity and the length of NAS. And we do know from the evidence that is available that patients that are on buprenorphine tend to have a shorter NAS. We also know that women who breastfeed their babies seem to have a shorter duration and less severity of neonatal abstinence syndrome. And skin-to-skin and rooming in are also things that can occur intrapartum that are helpful not only to the mother but also to the infant. So spending time with these women so that they know what to expect in the hospital and postpartum is really important. In talking about intrapartum care, we want to collaborate with the various specialties that would be involved with the patient, not only obstetrics, but anesthesia, pain management, and psychiatry. Collaboration between the disciplines to make sure that we're all on the same page with the physicians, the residents, the nurses, and the social worker. And these patients, for the management of their labor pain can significantly benefit from family support and from doula care. Multimodal pain control approach is needed, using not only neuroaxial analgesia, but injectable NSAIDs and acetaminophen, particularly if the patient has to have a cesarean section. And we want to really avoid drugs like butorphanol, nalbuphine, and pentazocin because they can precipitate acute withdrawal. So we mentioned that postpartum time period is particularly vulnerable. There are many physiologic symptoms that can mimic or be confounding, or exhaustion, achy, emotional states that women experience after delivery, and it can be hard to tell if they're experiencing withdrawal or if this is just normal postpartum stuff. The time is increased for vulnerabilities for these women, particularly if they are going to be going home without their baby, which is usually the case because in most institutions, any opioid-exposed infant is going to generally be observed for a pretty much set time limit to observe for the symptoms of NAS. And so that is usually somewhere between 5 days or so and 5 to 7 days. And that's usually much longer than the patient's going to stay in the hospital if they've had a vaginal delivery or even if they had a C-section. Naloxone is a short-acting opioid antagonist. It can rapidly reverse life-threatening opioid overdose and can and should be used in pregnant women who overdose. It can be administered sub-Q, IV, or intranasally. Naloxone kits can and should be prescribed for any patient using opioids, and if possible, we want to teach the family members how to use the kits before discharging the patient home from the hospital. So at University Hospital, we have what we call our Healthiest Beginning Clinic in Newark, New Jersey, and that clinic was created to have a focus on the effort to increase access to women with substance use disorder. The providers are OBGYNs with additional training in addiction medicine, and we are board certified in addiction medicine. So we provide not only the obstetrical and gynecologic care for these patients, but also in many cases we are the prescribers of the opioid, of the medication-assisted therapy that the patient's on. We coordinate care with the SUD centers in our community, so we can be prescribers, but if the patient is established with the program and established with counselors in a center, they can keep their current providers, and then we just manage their pregnancy or their gynecologic care. We also offer tobacco cessation treatment and with medications, as well as individual and or group counseling. So again, patients can, continue care with their primary substance addiction medicine provider, but we would still want to see them as an obstetrician. We have a special understanding of the role of breastfeeding, what to expect when they deliver, contraception, care coordination. And so we believe we offer a special service because we can really help to facilitate appointments with anesthesia, hepatology, as well as psychiatry. So, of course, most people are aware of the Prescription Drug Monitoring Program, and in New Jersey, that's the New Jersey PMPaware.net. And currently, we can interconnect with varying states, and I think this is probably even outdated because they've added quite a number of states. And so if the patient recently moved from Pennsylvania and New York, or any of the other states that are interconnected, it's very easy for us to be able to see what prescriptions they've been receiving, and that's really helpful. So I am a member of the New Jersey Maternal Mortality Case Review Team, and so we actually review all cases where a woman loses her life within 365 days of being pregnant, and that's regardless of how that pregnancy ended. And we're seeing more and more cases where opioid overdose, alcohol, and polysubstance use are involved when women die within a year after giving birth. Usually, many times the way we look at these deaths is we look at up to 42 days after pregnancy as being traditionally pregnancy related. But because our committee actually reviews deaths up to 365 days, we have those deaths are called pregnancy associated because they were associated with pregnancy. And we usually see the vast majority of deaths that are opioid overdose, alcohol, or polysubstance use are beyond the 42 days of the traditional pregnancy time period. And so I'm showing you this slide because I just wanted to point out that when you look at alcohol, drugs, tobacco, and STIs, again, of the total maternal deaths during this time period, and this time period was 2009 to 2013, more than 10% of these women had a drug or tobacco use history. So pregnancy-related death of a woman while pregnant or within 1 year is a cause related to or aggravated by her pregnancy, which is not accidental. Whereas pregnancy-associated death is a death of a woman while pregnant or within 1 year due to a cause unrelated to pregnancy. And so you can see simply in this slide that of the deaths that were pregnancy related, how many involved alcohol, drugs, and tobacco, 2, 4, and 9 cases. But you compare that to pregnancy associated, and you see 9, 29, and 29. So the point being is that substance use and overdose deaths are increasingly found to be major contributing factors to pregnancy-associated deaths in the United States. So what are the takeaway points? I think what I hope that we'll all take away is that the importance of universal screening for substance use in women is essential. To be aware that methadone and buprenorphine are both reasonable options for treatment of opioid use disorder in pregnancy. Women on medication-assisted therapy have better recovery rates than women who attempt to abstain from opioids. Counseling is needed in addition to medicine to deal with comprehensive recovery. Breastfeeding can mitigate neonatal abstinence syndromes in babies when women are stable in their recovery, and it can also reduce the risk of sudden infant death syndrome. Offering contraception early and often allows these women to recover further and help their recovery efforts and minimize unwanted pregnancy. And if we're thinking about prevention, increased focus on these women postpartum can help in reducing pregnancy-associated deaths related from opioid use disorder. And so these are some of our references, the ACOG committee opinion, ASAM, as well as the mother study. And there's many more, but these were just a few of the references that I bring your attention to that we use to prepare this presentation. Thank you.
Thank you very much, Dr. Campbell, for this very comprehensive presentation. I think as general providers, we can take a lot of this information to be able to treat a lot of our patients who may be pregnant, and that knowledge I think will be helpful for those who are actually in general medicine, so they can feel more comfortable prescribing MAT, particularly with methadone and buprenorphine, and just the information you provided, how it's quite safe to be able to use these in patients who are pregnant and have opioid use disorder. And a couple of things I think are important that you point out in your slides is that we often think the amount, the dose, is characterized by how much like side effects, or in this case, the neonatal abstinence syndrome that is experienced. And I think it's important to emphasize that the medication amount does not dictate the level of neonatal abstinence syndrome. So I just have a couple of questions for this presentation that I think is quite common that we tend to receive. Is that the first one is, if a patient is recently pregnant and is requesting to taper buprenorphine to reduce the risk of neonatal abstinence syndrome, what would be your recommendations and things the clinician should be aware of, especially when guiding and counseling this patient? And if they refuse to continue with buprenorphine, how would you respond? Would you still try to convince them to take the medication, or what would be the best approach to that?
Yeah, that's a great question. And I have learned over 20 years that unfortunately, I can convince people of a lot of things, but sometimes when patients are set in their ways, instead of me trying to convince them, sometimes it's good to take a step back and figure out where is their refusal coming from, because oftentimes if you can understand why they're refusing, what's the motivation behind their refusal, then you can really get to the crux of the problem. So, generally what I would say is that I don't recommend patients tapering off of buprenorphine during pregnancy, and this is extremely common. Patients always they want to know, when can I be off of this medicine? And so really I just try to convince them and to give them the evidence, more so than convince, to give them the evidence that what is their ultimate goal? And usually their ultimate goal is to be stable in their recovery, to do the least amount of harm to their baby. And so then I have to present to them the statistics that when they taper or they stop buprenorphine, they're increasing their risk for relapse, that their baby's going to go through withdrawal, and that's not a situation that we can control in utero. So for those reasons, I don't recommend it. If the patient refuses to continue, I try to understand a little bit more about why. And usually it's because they are worried about the effects of the baby. And I just try to point out to them that if they were using opioids that they were getting off the street, how many times would they have to use it? And how many times would they be going through withdrawals versus if they're on this medication? Ultimately, the patient gets to decide. But what I would recommend if they want to be off is to do a slow taper and to do it under medical supervision, not just do it by themselves.
Thank you for that response, Dr. Campbell. I think it's probably very important for patients to understand that neonatal abstinence syndrome, like long-term wise, has uh, really no long-term effect to the baby long-term. Would you agree with that?
Right, correct. And patients sometimes have the misconception that if their baby is born on buprenorphine or on methadone, that their baby is going to be addicted long term. And so again, it goes back to trying to allay some of those myths and fears. And what we can say is that because we typically will talk to patients about addictive behaviors and family history, and so that's probably where some of those fears come from. But again, we have to explain to them that it's actually much better for the baby, short-term and long-term, if the baby is born while they are in recovery and on medication-assisted therapy, as long as they're abstinent from illicit drugs.
Great, thank you. A couple more questions. Would you still consider methadone as the first-line treatment of choice for pregnancy for patients? Or would you consider just starting buprenorphine right away, given some of the more recent data?
Yeah, I mean, I think that as a physician scientist, just because we have that prolonged and those decades of use and experience, that we still do consider methadone first line. But I actually take the patient's individual situation in mind, and I generally offer the patient both choices up front, and then realizing that some patients will choose buprenorphine, and then they may need to switch to methadone. But again, a lot of times because of logistics, I can offer the patient buprenorphine and I can get them started in their recovery right away.
Mm-hmm.
And so I think that's beneficial. But I do talk to them about the fact that it's not the right thing for everybody. And they have to be open to change. Sorry.
And just regarding buprenorphine itself, do we need to switch, let's say, patients who are on the combination with buprenorphine naloxone and just buprenorphine itself? I know people are often still switching to the mono product. Do you feel, or in your practice, would you still continue patients on the combination product?
Yeah, I get a lot of patients who have been switched by their primary provider from the buprenorphine naloxone product, and then they've been switched to buprenorphine alone. If I have a patient who becomes pregnant, I generally do not switch them. I've had a few patients that got switched over, and oddly enough, they don't feel as stable in their recovery, so I've switched them back. But I feel that it's very fine for patients to continue on a buprenorphine naloxone product. I wouldn't routinely switch them over.
Yeah, and I think that's an important point to point out, actually, and emphasize that patients who are stable on Suboxone, or even new patients, we could start patients on Suboxone, the combination product, instead of the mono product.
Yes.
I think I have one more question. I think tends to come up a lot. So oftentimes we have some patients who have opioid use disorder, and they also have potentially ADHD or stimulant use disorders. But particularly with those who have ADHD and who may be on like an amphetamine like Adderall, if they learn they become pregnant, do you usually suggest patients, stop taking the ADHD medication?
Yeah, that's a kind of a tougher one. I mean, so in general, the evidence does suggest that we shouldn't use the stimulant categories in the first trimester. But again, it becomes a risk and benefit conversation with the patient, and also trying to see if you can lower the dose to the least amount that can keep the patient's symptoms under control. In reality, we haven't seen any birth defects, which is usually what people are most concerned about, is birth defects, which we haven't seen in patients who are on things like Adderall. But what happens, unfortunately, is patients go on the internet. And so even if you tell them, like, we haven't seen these birth defects, they go on the internet, and then the internet tells them, all these horrible things. And so then we're at odds. So it's a little bit tougher to make a decision about that. And I really try to decide with the patient, do they think they can, manage their symptoms outside of the first trimester? If they're already in their second trimester, it's less problematic.
Mm-hmm. Yeah, and I think for a general practitioner, if that comes up, I think it would be good to collaborate or consult with a specialty like your OBGYN physician such as yourself to really work through that plan with the patient.
Yeah, and the issue, for us that we see in the Newark area is that the patients end up coming to care late. And so many times they've already stopped the medicine before they've even come to us. As soon as they figured out they're pregnant and they stop taking, this is an issue not only with ADHD medicines, but even other antidepressants.
Mm-hmm.
And I'm always talking to the patients, like, if you're depressed, you're not eating, you're not taking care of yourself, then you're not doing a good job then you're not able to do a good job taking care of your pregnancy. So you have to be well first, then you're going to be able to nurture the baby inside of you.
Right.
But that conversation is best had when we have it very early.
Right. Well, I think that's all I have for the questions. So thank you very much, everyone, for participating in this learning collaborative. I hope you learned a lot in terms of opioid use disorders in this particular population. If you have any questions, please reach out to us at coe@njms.rutgers.edu. And please be sure to follow our listserv for the next learning collaborative. So thank you very much, Dr. Campbell, for your time.
Thank you.